Welcome to AETCM, the Emergency Medicine channel.
Yes.
One 72-year-old female patient came to ER with a complaint of acute onset of bilateral lower limb weakness. On initial 10-second assessment, patient was conscious and oriented. Going to primary survey, airway was patent, no gurgling or pooling of secretions. Coming to breathing part, saturation is 96 in room air. Respiratory rate is 16 per minute and bilateral equal entry. Circulation part BP was 90/60 millimeter mercury. Heart rate is 86 per minute and CRT less than 2 seconds. Going to disability, GCS is 15/50. People bilateral equally reactive to light. On checking power, 5/5 in both upper limb and 0/5 in both lower limb. GRBS is 126. Exposure part temperature was normal. Coming to the joint to primary survey, we initially take a VBG. VBG was there is no any acid-base abnormality. Lactate was 2.5. Potassium was normal. Sodium also normal. Taken a ECG. ECG showing normal sinus rhythm. Then basically patient presented with bilateral lower limb weakness. So according to a DD, we can rule out acute onset like trauma or any tumor obstruction or any Port's TB or any thrombosis or transverse myelitis or motor neuron disorders. So coming to secondary sort of sample history, 72-year-old female patient, known case of diabetic and history of aortic dissection type A 2018, admitted in outside hospital 2 days back with a history of acute onset of left lower limb weakness and urinary incontinence. There is no history of any facial deviation, slurring of speech or trauma. In that hospital, MRI stroke protocol was taken. There is no any acute infarct and MRI dorsal spine was taken which showed degenerative changes. After 2 days, patient developed acute onset of paraplegia, both lower limb weakness. There is no history of acute on chest pain, abdominal pain, back pain, no history of facial deviation, slurring of speech, altered sensorium, seizure, no history of trauma, fever or weight loss. Coming to examination, in CNS examination, patient was conscious and oriented. Power was 5/5 in both upper limb, 0/5 in both lower limb. Bulk was normal. Tone was loss of tone in both lower limb. Deep pendant reflex absent in both lower limb. Plantar reflex is mute. Sensory level below around T4 level, loss of pain and temperature in both sides, loss of vibration, proprioception and joint perception, and loss of fine touch sensation. Crude touch was preserved. Okay, so from our bedside, we done a echo showing aortic dissection starting from the ascending aorta. So vitally, patient BP is 90/60 and heart rate is 86.
Ascending aorta,
from
arch of aorta to descending aorta.
Descending aorta. To descending aorta. From echo, we done a flap seen from ascending aorta with mild AR and no RWMI. Then we done a CT aortogram. In CT aortogram, type A aortic dissection starting from arch of aorta. There is a re-entry site in the left common iliac artery and a thrombus in the false lumen. It causing 60 to 70% narrowing of the true lumen at mid and distal descending aortic vessels.
What is the BP?
BP 90/60.
90/60. Okay.
Then MRI DL spine with whole spine also done. It's showing short segment, predominant central cord T2 hyperintensity, area from D4 to D6 level, could be representative of spinal cord infection caused by the aortic dissection.
So there are two problems here. One is your aortic arch dissection or ascending aortic dissection extending down to the descending aorta. Second thing is your spinal cord lesion. Okay. So how do you correlate this to clinically? It is very difficult to correlate. Sometimes we may miss the diagnosis. Like this, we might end up in taking an MRI in the brain, spine, all these things. But if you take paraplegia, what are the reasons for paraplegia? Once you understand that, you can avoid unnecessarily investigation like MRI brain and all.
Acute paraplegia, we can DDs like trauma. We can rule out with port spine, thrombosis.
Basically, you divide that into spinal reasons for paraplegia.
Central reasons.
Central reasons for paraplegia. What are the central reasons for paraplegia?
Central
Brain. Why you are taking? Why a person?
tumor.
Where?
Both.
Huh.
Both.
Involving compression of both sides. Involve both sides.
But this is acute, no?
Both AC infected.
Acute infarct of the
Both
anterior
ACH,
cerebral
ACH.
artery. Both artery infarction is in dreams only. Eh? That is not possible. Then what is possible? But it is possible.
Before the division, large.
There is something called as unpaired anterior cerebral artery. Only one side, feeding artery will be only one side. And it will go to both sides. If that artery is blocked, then you can have paraplegia because of the central cause. Then parasagittal tumors, like you told, parasagittal tumors can have. But in that, if an acute bleeding occurs to that tumor, patient can have acute symptoms. Otherwise, it's a progressive symptom. Okay. So the most important condition is unpaired anterior cerebral artery thrombus. Okay. But how do it differ from the spinal cord lesion? Like you told, trauma, port spine, transverse myelitis, all
Reflexes, we can check. Spinal cord at the level, it is element palisade below human
What
line.
is the basic difference between spinal cord lesions and brain lesions in paraplegia? What is the basic difference? Most of the paraplegias, you get a sensory level if it is in the spinal cord. Whereas in anterior spinal artery thrombosis, nothing will be there. Only patient can have some social inhibition, paraplegia, all these things. But they never have a sensory level. Whereas whatever cause you take, like port spine, acute transverse myelitis, trauma, compressive myelopathy, everywhere you get some amount of sensory involvement. But compressive myelopathy, early time you may not get sensory level or sensory involvement. Late again you get sensory involvement. Okay, so that's the first thing. So unnecessarily doing an MRI in a paraplegia is not a good investigation. Okay, how do you localize in the spinal cord?
By sensory level, like in thoracic cervical spine, we can localize by -1, the vertebral column. From thoracic level, T1 to T6 by -2 to know the vertebral level. T7 to T9 -3.
Okay.
At T10 level is lumbar 1 and lumbar 2.
Okay. So from that you can probably tell which segment is involved in the spinal cord, and you can go for that area. You can go for MRI. Okay. Now there are something called as extramedullary compression, intramedullary compression, transverse myelitis, Brown-Séquard syndrome. What are these conditions?
In Brown-Séquard, one half of the spinal hemisection of the spinal cord is affected.
Okay. So the affected side will have loss of pain, temperature and weakness. Opposite side will have
below the lesion, opposite side of loss of pain and temperature. Below the
same side.
Same side, pain and temperature preserved.
Both are same. So pain and temperature.
Same side, opposite to the lesion.
Dorsal column on the same side with weakness. Opposite side, pain and temperature. That is Brown-Séquard syndrome. Whereas in transverse myelitis, what is the finding you get? Transverse myelitis. Full loss. So at the level, everything will be lost, including the deep tendon reflexes. Below that, after acute spinal shock, patient can have exaggerated reflexes. All the pain and temperature will be lost below the level. Okay. Whereas compressive myelopathy, like you get cervical spondylosis, compression on one side. How do they present? Compression from the right side, compressing the spinal cord like this. What will happen? So slowly compression occurs from the outside.
Motor fiber tract in the outside, like from sacrum, lumbar, these are the outside fibers, so they will affect first.
You are telling about sensory or motor? Motor. Okay.
So outside is lumbar and sacral fibers, and going inside it is thoracic cervical. So initially it will cause lumbar sacral fibers affected.
Okay.
Sensory. First cervical thorax.
Okay. But we theoretically think that it is like that, but it is not actually like that. When there is a compression, you can see the whole body of that side will be affected. Sensation, what you told is correct, it is slowly. That is because of the, whenever there is a compression, there will be veins in that area, they will become engorged. So they will become enlarged. They can even compress the spinal cord from in also. Okay, that's why most of the compressive lesions, you can see patients with the cervical spondylosis, they have whole side weakness. But theoretically, what you are telling is correct. Because of the compression, slowly you get affect one area. But practically, you don't see that. That is because whenever there is a compression, there is a compressive lesion. It also affects the blood supply of the spinal cord. That's why you clinically you don't see the pattern what you are explained, but theoretically that pattern is correct. Slowly it compresses from periphery to inward, so you get that progression. Okay, but in intramedullary lesions or intraluminal lesions which is expanding like syringomyelia, what is it? So they develop bilateral upper limb weakness and descending type of sensory loss, cape-like sensory loss which is descending. That is because
inside the cervical fibers first will be arranged
initially
inside
CTLS. So cervical fibers will be affected first, then thoracic, then it descends down, then finally you get sacral sparing. Okay, whereas other condition, sacral involvement is first. Okay, so that's why you can sometimes, if you examine in detail, you can get you can pinpoint where is the lesion. Okay, so that is possible. Okay, but other things are bladder involvement and your what is it, autonomic dysfunction, bowel bladder and autonomic dysfunction. That autonomic dysfunction is most important for an emergency medicine PG. Why it is emergency? Sorry, why it is important? Like you get transverse myelitis, like thoracic area, that is a common area for transverse. What is importance of transverse myelitis, which is admitted to your ICU? Anyway, he is having weakness. We are not going to do anything. Neurologist has to come and see. Plasmapheresis has to be done. But what is important for a ER physician or a intensivist? Hemodynamics. So suddenly you can develop these fluctuations of BP, pulse rate, all these things. Some patients can have tachycardia, some patients can have bradycardia, some patients can have tachybrady syndrome, some patients can have severe hypotension. So that all to be treated in an acute emergency. Then bladder involvement. How bladder involvement occurs in spinal cord lesions?
Spinal cord lesions, it is supplied by detrusor muscle and external sphincter. So,
where are the bladder fibers situated in your spinal cord? Is it central or peripheral? That is okay. S2, S3, S4 is the center, but from your anterior cortex, there will be like you want to urinate. Your anterior cortex will control it or void it. From there, one command will go to your this one bladder, and when the bladder is enlarged, you get a sensation to that area. So, where is these fibers? Where are these fibers? Is it central or peripheral? Is it central of the spinal cord or peripheral part of the spinal cord? These fibers are running centrally or peripherally?
sympathetic tract is going central.
It is centrally.
Centrally.
So that's why any expanding lesion like syringomyelia, bladder will be involved first. Whereas a compressive myelopathy like cervical spondylosis, bladder will be involved very last. Okay, but in transverse myelitis, everything is all of a sudden you get acutely itself. Your bladder is involved. Whereas in your cortical paraplegia, like you told, anterior cerebral artery thrombosis produces paraplegia. What will be the bladder involvement? You might have seen patients with dementia, frontal lobe dementia. What is the bladder? Social. So social inhibition is lost in the frontal lobe lesions. Okay, that is a problem. Whereas in spinal cord lesions, suppose there is a compressive lesion intramedullary or extramedullary where the bladder fibers are involved in C5, C6 level. What will happen to the bladder? It occurs very late only, but what will happen? It will become a UMN bladder. What is UMN bladder? Bladder will be enlarged. If you just tap it, void will occur. But LMN lesion like S2-3, what happens? Sacral lesions, bladder is involved. What is the type of bladder?
Incontinence.
What happens to the bladder?
Element
What is the element bladder?
retention.
Retention. Bladder will become very huge. Urine will be retained. Okay. Finally, urine will dribble out. Okay. There will not be any action at all. Bladder is completely atonic. Okay. Whereas other one, bladder is hypertonic. Bladder will be enlarging. Minimal stimulus itself, patient will pass urine. Okay. So if you know all these things, it will be good. But we'll take an MRI and see where is a lesion. But for that, you should know where actually where is a level. Okay. If you have a sensory level on the body, and if you can find out the spinal cord area where the lesion is, then it will be easy for us. Here, what is the reason? Here you have a patient who is having dissection of aorta. But how spinal cord is involved?
Basically, there's narrowing of the true lumen around 60 to 70%, and from this anterior spinal cord is separated by anterior spinal artery and posterior spinal artery. Anterior spinal artery and posterior spinal artery sometimes come from vertebral artery. Posterior spinal artery come from pike also. So in anterior spinal artery, after that is supplied by spinal cord supplied by posterior intercostal arteries.
Okay.
These arteries are branches of abdominal aorta and thoracic aorta.
Okay.
So if there is any embolic focus from this thrombus, it will cause us infection.
Not only embolic. So then when you can see the lumen of the artery is completely removed from the wall. Okay. So what happens? There will not be any effective circulation to that artery. So that anterior spinal artery or posterior spinal artery may suffer. If anterior spinal artery is suffering, what will be the clinical finding?
Then it will supply the major portion of spinal cord. Around anterior 2/3 supplied by the anterior spinal artery.
What all?
So anteriorly we have corticospinal tract, pyramidal tract,
Okay.
and anterior and lateral spinothalamic tract, and up to T2 level sympathetic tract is there.
Okay.
So in cortical tract affected, human like palsy will affect.
So you get weakness.
In acute phase, there is absence of reflex, then it becomes hyperreflexia.
Okay.
Then loss of
Pain and temperature sensation will be lost. Whereas posterior spinal
dorsal
artery,
column affected, there is joint proprioception, vibration sense,
but there will not be any weakness.
no weakness.
Okay. So that will be the clinical finding. Bladder will be involved in anterior spinal artery. Posterior spinal artery, it may not be involved. Okay. Here, what was the clinical finding?
Clinically, there is patient mixed sensation is there.
Okay.
Sir.
So this is a patchy sensory loss. Okay. It is not like transverse myelitis. Some arteries are blocked. So it is like a patchy sensory loss. Bladder?
Bladder patient person incontinence of urine.
Incontinence. So that bladder fibers are also involved because they go through the central part of the spinal cord that is supplied by the anterior spinal artery.
Then aortic dissection classification, there is two types of classification. One is Stanford classification and DBK classification.
Okay.
Stanford classification we can classify it to type A and type B. In type A, it will affect the ascending aorta, arch of aorta, and up to abdominal aorta. Type B is ascending aorta and arch of aorta is not affected. Other than that, it will affect. And in DBK, type 1 is like Stanford type A. Type 2 is like it only affect the origin of the aorta, that is ascending aorta. Type 3 is divided into type 3A and type 3B. Type 3A is from distal to left subclavian artery up to proximal to celiac artery. Type 3B is distal to subclavian artery and it will extend up to celiac artery.
Okay. So how do you manage this case?
In type A, morely
in emergency.
In emergency,
we are not talking about surgery or Bendal procedure that is done for aortic repair.
In emergency management, first of all, patient person.
So you have two scenarios. One is a dissection of aorta with high BP. One is a dissection of aorta with low BP. How do you manage both?
Dissection of aorta with high BP, let's just take like hypertensive emergency. We will control the BP. Initially, if there is no any bradycardia, we can go with on injection labetalol.
Okay.
Labetalol 0.25 mg per kg we can give. We can repeat the dose like 10 mg. We can repeat dose every 10 to 15 minutes. Maximum dose is up to 300 mg. Control the BP. Our target BP is 200 to 120 mg per hour. Mercury. Then if the patient is present with acute pain, we also go with pain medication like initially we can start with paracetamol, then we can go with opioids.
Okay.
Then if low BP, BPs.
How you manage this case? This patient had low BP. How do you manage?
Our target BP is 100.
So no need to increase the
increase
BP
the
like a
BP.
normal person. Just to maintain the internal circulation,
Perfusion.
that is more than sufficient. So 100 by 80, 100 by 70 is okay. So how do you manage?
If there is low BPs because of hemorrhagic shock, we can give blood transfusion.
Okay.
Otherwise we can.
Normally, how do you manage the BP?
Fluids, initially fluids, then or
So
initially
here fluids you may not give because again it may produce volume expansion, volume overload, and bleeding can increase. Vasopressors only that is only available choice till the patient is taken to OT and start operating. We have to give vasopressor like noradrenaline can be started, dopamine can be started. Only thing it has got its own demerits. Like a patient can become bad very fast if you don't take the patient for surgery. There will not be any other choice when the BP is very low. You have to start noradrenaline and take the patient to OT. Okay, what procedure they'll do?
in this patient, they are planning for DSA, which level is the spinal artery is affected.
Okay.
Patient was power was from 0/5 it becomes 2/5. Tomorrow they're planning for DSA to know which level is there.
What is Leriche syndrome?
Leriche syndrome, there is thrombosis of the celiac trunk of abdominal aorta, so it will affect causes severe pain, claudication pain, a pain over the buttocks area, absence of femoral pulse in male, erectile dysfunction also will affect it.
Okay. So that is also like it's a thrombus. Here it is a dissection of aorta.
Dissection plus thrombus also.
Thrombus is also there. Other one is a pure thrombus. Okay. That also can present with same all these problems. Spinal artery, artery of Adam Lewis, and spinal arteries are involved. Patient can present with paraplegia. So that is also one of the cause for paraplegia. Okay. Anything else?
According to in aortic dissection from ER side, we can some signs is there like pulse deficit, pulsus paradoxus, difference of BP in bilateral upper limb and lower limb. From if ascending aorta is affected, we can check the BPs of both upper limbs. If there is more than 20 millimeter difference in the BP, we can suspect that aortic dissection with the patient presented with throbbing like shivering like pain. Then pulse deficit also we can make a DDs like aortic dissection will be there.
Doppler? Handheld Doppler is the easiest thing.
To check the
peripheral pulses in the lower limb, compare with the upper limb, that will be low.
Then we can, now there is studies there, aortic dissection score is there, like checking with D-dimer also. Just not fully specific. If we can exclude the patient aortic dissection with checking the D-dimer also. If it is more than 500, we will suspect there is aortic dissection. If it is less than 500, we can exclude aortic dissection.
What is the problem of D-dimer?
D-dimer is elevated in lot of conditions. Like
D-dimer is elevated in most of the conditions, including myocardial infarction, pulmonary embolism, dissection of aorta, infections. So if patient is absolutely normal, pain is due to some gas, then you can see D-dimer.
Less than 500, we can exclude aortic dissection.
Aortic dissection. Very high D-dimer indicates some
more than
severe
500.
problem. Okay, that's all. Okay, anything else? Nothing. Okay, thank you.